Good day, doctors. Welcome to Astra Zeneca Philippine Symposium, here at the 2021 Annual Convention of the Philippine Society of Endocrinology, Diabetes and Metabolism. And to give us a presentation, let us all welcome our speaker for today. He is a professor of kidney medicine at University College London, UK, and honorary consultant nephrologist at the Royal Free London NHS Foundation Trust. He is a clinician scientist interested in the complications of chronic kidney disease, specifically those that increase the burden of cardiovascular disease and/or accelerate progression of kidney failure. He has participated in the development and running of several large-scale clinical trials testing lipid-lowering regimens, calcimetrics, and sodium glucose cotransporter 2 inhibitors in patients' chronic kidney disease. He has developed clinical practice guidelines for several organizations, most recently for kidney disease, improving global outcomes, of which he was co-chair from 2012 to 2019. He is currently chair of the International Society of Nephrology Advancing Clinical Trials Committee. Previous roles include President of the UK Renal Association and Chair of the UK Renal Registry. He is currently National Institute for Health Research National Specialty Lead for Nephrology. At a local level, he is Co-Medical Director of the NIHR North Thames Clinical Research Network and Lead Clinician for the Center for Clinical Kidney Disease within the Department of Renal Medicine at University College London. Ladies and gentlemen, Professor David Wheeler.
Thank you very much for this opportunity to speak to you in the Philippines. It's my pleasure to talk to you about the DAPA CKD study. As you've heard, I live in London. I work as a nephrologist at University College London. My relevant disclosures are shown on this slide.
This is a non-promotional medical meeting, and there is no intention to encourage off-label practices. Dapagliflozin is indicated in adults with type 2 diabetes mellitus for the treatment of diabetes as an adjunct to diet and exercise. Dapagliflozin is approved in the Philippines for the prevention of new and worsening heart failure or cardiovascular death in adult type 2 diabetes patients. Dapagliflozin is now approved in the Philippines for the prevention of new and worsening nephropathy in adult type 2 diabetes patients. Dapagliflozin is now approved in the Philippines for the treatment of heart failure with reduced ejection fraction in adult patients.
So this is the sort of patient I look after. This is a 73-year-old man. He's had type 2 diabetes for 15 years. He's reached end-stage kidney disease as a result of his diabetic nephropathy, and he's now on our hemodialysis program. He shows up for treatment in one of our dialysis units 3 times a week. He has other diabetic complications, including retinopathy. He's got macrovascular disease with coronary artery symptoms, a transient ischemic attack, and peripheral vascular disease with a left midfoot amputation and an ulcer on his right heel. And he's also got signs and symptoms of autonomic neuropathy. This is a really poor situation for this patient to end up in, as you will appreciate. And although this is the type of patient we look after in my specialty, we really want to prevent this sort of thing happening. We want to treat these patients much earlier than end-stage kidney disease. We want to slow down the progression of their deteriorating kidney function, and we want to keep them off dialysis. So one way that we have tried to do this is to classify chronic kidney disease so that we all understand the stages, and as a result of the staging system, we can possibly pick up patients earlier. So this is the Kidney Disease Improving Global Outcomes International Classification System for Chronic Kidney Disease, We classify patients according to a G stage, that's the estimated GFR, and an A stage, that is the amount of albumin in the urine, and we use a spot urine and an albumin to creatinine ratio. And so you can see here, the grids, the colors represent risk, the risk of progression to end-stage kidney disease and the risk of cardiovascular complications. And so these are the patients who perhaps we should be focusing on. These are patients who do not have a reduced GFR. They have a GFR of greater than 60 mils per minute. And by definition, they don't have chronic kidney disease unless they have albuminuria. So if your GFR is above 60 mils per minute, you need another marker of kidney damage to make a diagnosis of chronic kidney disease. And that's commonly albuminuria. So if these patients have albuminuria in the range above 30 milligram per gram, as you see here in the A2 column, then you can diagnose them as having kidney disease. And I think these are the patients that we want to pick up and treat, as I say. What we want to do is stop these patients progressing to the later stages of chronic kidney disease, the later G stages, G3A, 3B, G4, and G5. And we know that those with the higher levels of albuminuria are more likely to progress down this pathway. So let's look at a patient with earlier diabetic kidney disease. This is a 67-year-old male. He's overweight. He's had his type 2 diabetes for 10 years. He has other diabetic complications. He has retinopathy. He has a blood pressure that I would argue is too high. The American Diabetes Association suggests a target of 140/90. He's 148/92. He has an HbA1c of 8.6%, with the ADA target being between 7 and 8. So his diabetes isn't particularly well controlled. And he has a GFR of 42 mils per minute. And we know that a year ago, his eGFR was 53 mils per minute. So his kidney function is declining, and it's declining fast. He has albuminuria. He's in that A3 category with an albumin to creatinine ratio of 345 milligram per gram. So this would be picked up on a dipstick. And he's on a variety of medications, including irbesartan in a maximal dose. Now, as a nephrologist, I'm often referred patients like this and asked to comment on management. I always want to see that these patients are on maximized doses of ACEs or ARBs, because these drugs we know slow deterioration of diabetic kidney disease. But there's a lot more that we could possibly do for this man to prevent him progressing to dialysis. And as his eGFR does decline, we've also got to think about the management of his diabetes and which drugs we might use. So going back 20 years now, we had trials of angiotensin receptor blockers in patients with type 2 diabetes. Here on the left, you see the Renal trial. On the right, you see the IDNT study, losartan versus placebo on the left, irbesartan versus placebo with an amlodipine arm on the right-hand side. You're looking at proportion of patients reaching end-stage kidney disease over time. And you'll see a reduction in the patients reaching end-stage kidney disease in the group randomized to the ARB versus the placebo, and in fact a benefit on the right-hand side over the amlodipine arm in the IDNT study. So over and above placebo, over and above other blood pressure medications, angiotensin receptor blockers reduce the number of patients reaching end-stage kidney disease. But you'll see from these graphs that there was still a large residual risk. There were still patients that progressed despite these measures. Remember, this was 20 years ago, and it's only really in the last few years that we have seen new therapies coming along. And these are the drugs that we as nephrologists are most excited about, the SGLT2 inhibitors. This is from our own UK national formulary. These are the 4 gliflozins that we have available in the UK with the dose ranges. And nephrologists are interested in these drugs because they work in the kidney. So on the left here, you see a proximal tubular cell. You see the brush border with the SGLT2 and SGLT1 co-transporters, so sodium glucose co-transporters, responsible for the reabsorption of sodium and glucose from the urine into the proximal tubular cell and on from there into the blood. So these transporters reclaim filtered sodium and glucose. So if you look on the right-hand side, you see the nephron. A normal individual will filter about 180 grams of glucose every day, but we reclaim all of that glucose in the proximal tubule, largely as a result of SGLT2 activity, 97% reabsorption, and a little bit as a result of SGLT1 activity, around about 3% of the filtered glucose. And in a normal individual, as we're all aware, there should be no glucose in the urine. Now, in diabetes, because of a higher blood sugar and a higher filtered glucose load, around about 300 grams a day, the SGLT2 and SGLT1 co-transporters are upregulated. So they're working harder or trying to work harder. What we do with SGLT2 inhibitors, of course, is that we inhibit the activity of the SGLT2 co-transporter. This leads to a reduction in the reclamation of glucose in the proximal tubule, and it leads to an enhanced appearance of glucose in the urine, and with that sodium. So these drugs are effectively proximal tubular diuretics. They enhance sodium excretion as a result of blocking both glucose and sodium in the proximal tubule. Now, as we're all aware, these drugs have some useful benefits. They reduce blood sugars. This is why they were developed. They enhance glucose excretion. That's the way they work. That leads to a reduction in calorie load and to a useful weight loss in most patients. And they lead to an osmotic diuresis, which leads to a reduction in blood pressure. So all potential benefits, of course, in a patient with type 2 diabetes. Now, as with all new glucose-lowering drugs, these drugs had to undergo cardiovascular safety studies, and we're all well aware of these studies, and I've highlighted the cardiovascular safety studies of the SGLT2 inhibitors in red here: EMPA-REG, CANVAS, VERTIS, DECLARE, and most recently, the SCORED study. Now, these studies were, as I say, required to prove that these drugs were safe from a cardiovascular perspective. But the investigators running these studies also looked at kidney endpoints. So they looked at changes in EGFR, they looked at albuminuria, they looked at doubling of serum creatinine, they looked at patients starting dialysis. And we can learn from these studies, if we look at the renal endpoints, in the middle boxes here, you'll see the different renal endpoints in the different studies. And on the right-hand side, you will see reductions in those renal endpoints in 3 out of these 4 studies. Now, these are largely biochemical changes. These are largely reductions in EGFR. Very few patients started on dialysis. But the trends here and the reductions here are in the right direction. Fewer patients doubled their creatinine. Fewer patients showed a decline in EGFR. And fewer patients actually started dialysis, although there were very few of those events. So this was really exciting for nephrologists. Might these drugs improve outcomes, kidney outcomes, in patients with type 2 diabetes? Now, let's just have a little bit of a reality check here, because in fact, the majority of patients recruited to these cardiovascular safety trials did not have kidney disease. They all had GFRs above 30 mils per minute. They're not the type of patients nephrologists deal with. And if you take the mean EGFR and the median level of albuminuria of the patients going into these studies, these fall within the normal range. So I've plotted on our kidney function grid here the EMPA, CANVAS, DECLARE, and VERTIS studies showing where the patients sat in terms of kidney function. The mean EGFR was normal. The median UACR was normal. These patients fall in this green box here. They don't actually have chronic kidney disease by definition, at least the majority of them. So we have to remember that when we interpret the results of these studies. So what nephrologists wanted to do was to take the type of patients we look after with more advanced chronic kidney disease and recruit those patients into a trial of SGLT2 inhibitors. And we did that initially with the Credence study. We took patients with an eGFR between 30 and 90 who all had albuminuria greater than 300 milligram per gram. So they're in this higher range of albuminuria here, the A3 category. And we randomized these patients in a trial to canagliflozin or to placebo. Now, all these patients had type 2 diabetes, and all of these patients, bar a handful, were on ACEs and ARBs. And if at all possible, those drugs had been maximized prior to the trial. So an adult patient population, GFRs between 30 and 90, all with albuminuria, all on standard of care ACE ARB therapy, as the guidelines recommend after those trials I showed you from 20 years ago. After a run-in period, these patients were randomized to canagliflozin 100 milligrams or placebo, followed up at regular intervals. And let me just make the point that we didn't stop the drugs if GFR dropped below 30 during the study. So patients remained on study drug, even if GFRs dropped below 30. And we have some data from that patient population who effectively had stage 4 chronic kidney disease. Now, the results of this trial were presented back in 2019 before the COVID pandemic. We were delighted to see a reduction in this composite primary endpoint, which was the development of end-stage kidney disease, the doubling of serum creatinine, and or death due to either a kidney cause or a cardiovascular cause. So we're capturing a wide range of kidney events here, and we've also got cardiovascular death in the endpoint because it's often difficult to distinguish cardiovascular from kidney death in end-stage kidney disease. So these events occurred, or a first event occurred in 245 participants randomized to canagliflozin, 304 participants randomized to placebo, a 30% risk reduction with a statistically significant p-value. So that was good news for our patients in nephrology. On top of that, we also saw benefits on some cardiovascular outcomes. And this is the standard MACE outcome of cardiovascular death, MI, and stroke. And let me just say that we really worry about these events in these patients. Not only do these patients progress towards chronic kidney disease, but many of them sustain cardiovascular events along the way. And this is the standard MACE from the statin trials. And we see a reduction here of 20% in terms of risk reduction of 20% for this composite of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And then consistent with the other trials, the cardiovascular outcome trials, we also saw reductions in this composite of cardiovascular death or hospitalization for heart failure. And this was driven largely by reductions in hospitalization for heart failure, fluid overload, which is a big problem in this population. Again, statistically significant reduction. Now, what happened to GFRs during the Credence study? And I think it's important to look at this to understand how these drugs might be working. And this has important implications for our prescribing of these drugs. This is estimated GFR over time during the study. We had an early blood sample at 3 weeks, and we detected an acute drop in estimated GFR greater in the canagliflozin group than the placebo group. A minus 3.72 mil per minute per 1.73 meters squared reduction in those randomized to canagliflozin, a 0.55 reduction in those randomized to placebo. Now, remember, we're trying to preserve kidney function, and this is a reduction in kidney function. Okay, that we, of course, see with ACEs and ARBs. We think this is something to do with a change in glomerular hemodynamics that in the longer term may be protective. And indeed it is. So if we project these lines out over the course of the study, you'll see that the slope of the canagliflozin line is flatter than the slope of the placebo line. There's a crossover here at 12 months. After this initial reduction, the patients randomized to canagliflozin showed a slower progression of their kidney disease. over the course of the study. And this, of course, should translate into a later start on dialysis. And there were fewer dialysis starts, we know, in this patient group. So what's going on? Well, this is a schematic diagram of the glomerulus showing the afferent and efferent arteriole. And if we look at the top part of the diagram, you'll see what happens when we start a patient on a RAS blocker. We dilate the efferent arteriole, the outflow from the glomerulus. This reduces the pressure within the glomerulus, and this leads to an acute reduction in eGFR. But in the longer term, the glomerulus is functioning at a lower pressure and is protected. Remember that in credence, all of our patients were already on ACE and ARBs, so we already had this vasodilatation of the efferent arteriole. What we think the SGLT2 inhibitor did was to constrict the afferent arteriole, leading to a further reduction in intraglomerular pressure and further kidney protection. That's a hypothesis, it's not been proven, but it does or could explain how these drugs work on top of ACEs and ARBs. The other interesting thing was that despite these acute reductions that we saw in estimated GFR, we did not see an increased risk of acute kidney injury. And I think this is really important for those of us prescribing these drugs. Here on the left are all renal adverse events during the study. There were actually fewer renal adverse events in patients randomized to canagliflozin. And on the right, investigator-reported acute kidney injury. There was no increased risk of acute kidney injury. Highly reassuring when we know that this drug reduces eGFR. And finally, from the credence database, we looked at the effect of drug in those patients who went into the study with an HbA1c of less than 7%, and those patients who went into the study with an HbA1c of greater than 7%. And you'll see here that same slowing of the rate of decline of eGFR in these two patient populations. So the kidney protective effect didn't seem to be linked to poor or suboptimal control of diabetes. And that's an important fact as we move into the next study, which I'm going to talk about, which is the DAPA-CKD study, where we extended the use of these drugs to patients who had non-diabetic kidney disease. So let's look at DAPA-CKD. Similar concept, similar study, eGFRs between 25 and 75, urinary albumin creatinine ratios are greater than 200, so slightly lower levels of albuminuria recruited into this study and slightly lower levels of eGFR. So a patient group with more severely impaired kidney function. And the mean eGFR in these patients turned out to be around 13 mils per minute, lower than in credence. Now, patients needed to have an eGFR and a UACR, as I've stated. They needed to be on maximum tolerated doses of ACEs and ARBs, just as we did in credence. But it didn't matter whether or not they had type 2 diabetes, as long as they fulfilled these GFR and UACR criteria. We excluded patients with type 1 diabetes, we excluded patients with polycystic kidney disease, and we excluded patients with immune-mediated kidney disease that the investigators felt required immunosuppression. We randomized patients 1-to-1 to dapagliflozin 10 milligrams or placebo. This was an event-driven trial. We never actually accrued 681 events as we were planning to, because the Data Safety Monitoring Committee advised us to stop the trial early because of overwhelming efficacy. So we recruited 4,304 participants from around the world, including an important contribution here from the Philippines. So thank you to all of you who participated in this study. Of those that we recruited, 2/3 had type 2 diabetes as a comorbidity, but 1/3 did not have type 2 diabetes. So this was non-diabetic, proteinuria chronic kidney disease. Our primary outcome was similar to credence, except instead of a doubling of serum creatinine, we had a greater than or equal to 50% reduction in eGFR. We included end-stage kidney disease and renal or cardiovascular death in the endpoints. And then we had 3 secondary endpoints that we analyzed in a hierarchical order. So we could only move on to the next one if the previous one was statistically significant. We had a kidney endpoint, which is the primary endpoint without cardiovascular death. We have the cardiovascular death or hospitalization for heart failure endpoint. And we also had, as our third secondary endpoint, all-cause mortality. So here's the primary outcome presented at the European Society of Cardiology last September. Again, as we saw in Credence, a reduction in this composite primary favoring dapagliflozin over placebo, 197 events versus 312 events, a 39% risk reduction. And there's the p-value. You need to treat 19 patients for 32 months to prevent one of these events. So that was good, consistent with the Credence result, and we'd included patients who didn't have type 2 diabetes. Here are two of our secondaries. We hit the first secondary, the kidney endpoint. Results were very similar to the primary. Here is cardiovascular death or hospitalization for heart failure. This is the, or very similar to the endpoint in the DAPA-HF study, a study of dapagliflozin in heart failure patients, hazard ratio 0.71. And then we also hit the all-cause mortality endpoint. There were fewer deaths in the patients randomized to dapagliflozin compared to the patients randomized to placebo. And this was obviously nice to see. Not only were we preventing patients ending up on dialysis, but we were also reducing mortality rates in this high-risk patient population. So the big question is, did it matter if the patients had diabetes or not? And the answer is no. This is the primary outcome at the top and the three secondary outcomes. In the blue band here, you'll see the overall result. But if you look in the white band, you'll see the results subdivided into patients who went into the trial with type 2 diabetes and patients who went into the trial without type 2 diabetes. And you'll see here, there's actually no differences between the diabetic and the non-diabetic group. And that's proved by looking at this p-value on the right-hand side, the p for interaction. If this is not significant, then these values are actually not significantly different. And you'll see that for all of the endpoints, these values were no different. The drug had an equal benefit in those with and without type 2 diabetes. Did it matter what the cause of kidney disease was? Well, we asked the investigators to report the cause of kidney disease. You won't be surprised to know that not all the patients with diabetes were actually reported as having diabetic nephropathy. In fact, 13% of the patients with diabetes had another diagnosis. So here's the analysis by cause of chronic kidney disease. We've got diabetic nephropathy. We've got ischemic hypertensive nephropathy. We've got a number of different types of glomerulonephritis, the glomerulonephritidis, and we've got other or unknown causes of chronic kidney disease. Here's the primary and the three secondary endpoints. Again, there's a bit of variability here, but if you look at the p-values for interaction, there are no significant differences between these subgroups. The benefits were consistent regardless of the underlying diagnosis, i.e. the cause of chronic kidney disease. Now we have to think about safety, particularly moving outside diabetes. Is it safe to use an SGLT2 inhibitor in a non-diabetic population? So here's safety from the DAPA-CKD study. We've got discontinuation of drug due to adverse events. We've got serious adverse events, and we've got some adverse events of special interest. And we've divided the patients here into those with and without diabetes, and we've divided them according to their treatment allocation in the study. And you'll see here that importantly, there are no episodes of diabetic ketoacidosis in those patients with dapagliflozin in those patients with diabetes randomized to dapagliflozin. Now, this was a bit of a problem in the Credence study. We saw more diabetic ketoacidosis in the canagliflozin arm than the placebo arm. We did not see that in the DAPA-CKD study. And in those without diabetes, we saw no ketoacidosis in either the DAPA or the placebo groups. The other one I want to look at is major hypoglycemia at the bottom, a balanced distribution in those with diabetes, but no hypoglycemia in the patients who went into this trial without type 2 diabetes. There were no other worrying safety signals that we saw. We saw the expected mycotic genital infections that we know are associated with these drugs, but there were no strong signals for amputation or for any other outcomes of interest. So let's look at the GFR again, and we see exactly the same as we did in the Credence study. We see this acute drop in eGFR at the first blood sample. This was actually at week 2 in this study, and then we see this stabilization of the rate of decline in kidney function over time, remembering that a third of these patients do not have type 2 diabetes. So again, this is very similar to what we saw in Credence and suggests that these drugs have an effect acutely on glomerular hemodynamics, which in the longer term is associated with preservation and protection of kidney function and a delay in starting dialysis. So we can actually put DAPA-CKD together with DECLARE-TIMI 58, which was the cardiovascular safety study of dapagliflozin, and I showed you data from this early on, looking at the kidney outcomes that were reduced in that patient group randomized to dapagliflozin, and you can see here the DAPA-CKD study with a similar pattern of benefits. And if you look at the bottom here, we're actually looking at a wide spectrum of patients if we combine these two studies together. So yes, in DAPA-CKD, we looked at patients with more advanced chronic kidney disease, but we also know from DECLARE that in patients with type 2 diabetes who have early signs of kidney disease, who are developing albuminuria, who are starting to show reductions in eGFR, that there are also benefits in that population. So I would argue that it's probably never too early to start these drugs if you want to protect patients' kidneys. And indeed, that's the position that some of the guideline groups have now taken. So this is from KDIGO, Kidney Disease Improving Global Outcomes. This is a new guideline that was published last year. The publication was actually delayed because of the SGLT2 inhibitor studies coming out. And the authors of these guidelines, the experts who wrote these guidelines, have actually placed SGLT2 inhibitors here in this pyramid as a therapy that most patients should be receiving. So if you go to the bottom of the pyramid, here are your lifestyle changes, your lifestyle management. The second tier of the pyramid are the essential drugs. And on top of RAS blockade now, the KDIGO group added SGLT2 inhibitors and then antiplatelet therapies in some patients. And if you look at practice point 4.1 at the bottom here, in terms of treating glycemia, SGLT2 inhibitors have been put up there as a first-line therapy alongside metformin. So these drugs have been promoted in these guidelines. Now, we do have a few challenges, and this is one of them. This is a slide from the UK from the middle of 2019. So it's a little bit old now, but what it does show is GFR across the top and the licensed indications for the different SGLT2 inhibitors. And you'll see that certainly in June 2019, none of these drugs had a license for use in patients who had an eGFR less than 45. Now, I've just shown you data from patients down to 25 ml per minute. So the regulators will presumably now and are now looking at the data from these new trials and these views on prescribing at lower eGFRs are changing. So why were these drugs limited in terms of their use at lower eGFRs? Well, it's because they didn't lower HbA1c. If the kidneys aren't working so well, these drugs don't lower HbA1c, and they were developed as drugs to reduce glucose, blood glucose in patients with type 2 diabetes. So I think things will catch up, and certainly following the Credence study in America, the canagliflozin license has changed, And there's an ongoing process now, a fast-track process to look at dapagliflozin in the US. So hopefully we're going to see the licensing change, and we'll be able to we'll be freer to prescribe these drugs as clinicians. So just to summarize, I hope I've shown you that the SGLT2 inhibitors are of great interest in those of us who look after patients with chronic kidney disease. We got some nice signals from those cardiovascular outcome trials that were mandated. We saw from credence that in patients with type 2 diabetes and CKD, these drugs have kidney and cardiovascular benefits on top of ACEs and ARBs. We saw in DAPA-CKD that these benefits extend to patients who have CKD due to causes other than type 2 diabetes, and remarkably, in my view, have mortality benefits in this patient population. And fortunately, these trials haven't highlighted any unexpected side effects that are going to make this drug class difficult to use in patients with chronic kidney disease. I'd like to thank you for listening to me and hope that that was of value to you. Thank you very much.
Thank you, Professor David Wheeler. We shall now proceed with the Q&A session. First question from Dr. Mitos Cabral. Is it advisable to start a patient on an SGLT2 inhibitor if their diabetes is very uncontrolled?
Yeah, so I think we need to be careful in a patient with poorly controlled glycemia. Now, I'm not a diabetologist, and I've got to become more comfortable using SGLT2 inhibitors in my patients. But I think it's probably wise not to rely on these drugs as the sole drug to improve glycemia in a patient who's poorly controlled. I think we need to look at other therapies, GLP-1 receptor agonists. We need to look at, what other drugs these patients are on. Should they be on insulins? And of course, we can start these drugs in patients who are on insulins. But I don't think they're a good drug for acutely improving control in a poorly controlled patient. I think they are, however, a tool, if you like, in the toolbox to improve glycemic control over time. And I think they're a good drug to use alongside other agents, but shouldn't be used as the sole agent to fix a really poorly controlled diabetic patient.
Next question from Dr. Mitos Cabral. Can SGLT2 inhibitors be prescribed safely to patients who have had kidney transplant or those who have a solitary kidney?
Yeah, great question. Let me do solitary kidney. I think that's okay. The worry might be if the patient with a solitary kidney had a renal artery stenosis, just as with ACEs and ARBs. This could lead to a large reduction in EGFR. And I would certainly, if I had a patient with a solitary kidney, I'd certainly make sure I did a blood sample 2 to 3 weeks after starting the SGLT2 inhibitor. Transplant recipients, a lot of my colleagues are asking this. This seems like a really good drug to use in a transplant patient population where you've got a problem with the development of post-transplant diabetes, but we really have limited experience, and I think we should be cautious. There are some case series published. There's people who publish their experience in small numbers of patients who've had transplants and had these drugs. And there'd be no major disasters, I don't think, in that patient population. But I think if we do use these drugs in renal transplant recipients, we have to recognize we're using them way out of license, and we need to be really cautious. And we certainly need to watch out for, the opportunistic infections, the mycotic genital infections, which can, of course, lead on to more serious soft tissue infections, or could lead on to more serious soft tissue infections. And I think we need to look out for urinary tract infections, although they're not a huge problem in other populations. They might be more of a problem in a population of patients who've received a kidney transplant.
Next question from Dr. Elaine Cunanan. We expect a transient dip in EGFR. How early should we check creatinine after starting an SGLT2 inhibitor, particularly for those with moderate to severe CKD?
Yeah, great question. So there will be a drop in EGFR. It may be as much, I mean, in the studies, there were some patients who dropped EGFR by, 15, 20%. I think the really reassuring fact from these studies is that these drugs are not causing acute kidney injury. So there are people who argue that there's no need to check EGFR after 2 to 3 weeks because we're not seeing any harm. And if we start checking EGFR, we're going to start worrying about GFR and we might start taking the patients off the drug. I think that's a difficult position because we're all cautious by nature. So I think if you're worried about your patient, if your patient is elderly on high doses of loop diuretics, frail, you're particularly worried about that patient, I think it's very reasonable to check an EGFR at 2 to 3 weeks. And I think a reduction in EGFR of greater than 30% should make you stop and think about whether you're doing the right thing. Whether EGFR checks are required routinely after 2 to 3 weeks in all patients, I'm not sure. And I'm not entirely convinced that that is a necessary thing to do, bearing in mind the kidney safety profile that I've talked about. But I think, the guidelines may help us with this, and maybe, the regulators and the experts will make a judgment.
Next question. Considering the benefits in terms of kidney protection, once started, do we need to stop if EGFR is less than 30?
So another great question. We've just published some data from the Credence study actually showing what happened in those patients who actually started with an EGFR below 30. So you screen your patients for the study, their GFR is above 30, you bring them up on the first day, you randomize them, and their GFR is below 30. You still put them in the study. And we looked at what happened to those patients, and they still seem to show benefits consistent with the overall study population with no excessive harm. In both Credence and APA-CKD, investigators continued to study drug right down to the patient starting dialysis. They weren't required to stop study drug when EGFR dropped below 30 or 25 in APA-CKD. We're looking at the DAPA data, obviously, but we don't seem to see any major issues. I've even heard of investigators continuing the drug when the patients are on dialysis. And I'm really not sure whether that's going to be good, because when you stop passing urine or when you pass very little urine, presumably these drugs are not doing a lot. But, I'm assuming we understand the mode of action, and maybe there are other benefits that aren't related to the urine output. So, I think to answer the question, we're not seeing any adverse safety signals in patients with the low levels of EGFR stage 4 CKD.
Thank you, Professor David Wheeler.